Good morning, everyone. Uh, Thank you for giving me this opportunity and thank you for being here on a Sunday morning. So, I would like to talk about diabetic control in the elderly. What I intend to say is tight control is not always right control. So, certain de-prescribing guidelines that I would want to highlight. Now, taking a case study. So, there is Mrs. D who has a HbA1c of 6.4%. She is on basal bolus regimen of insulin and her history is significant for having 2 falls in the past 3 months. She suffers from mild cognitive impairment and her GFR is 38 ml per minute. Now, is she being controlled excellently or are we over-treating her? This is a question. Now, if we see her ambulatory glucose profile, we can see here that even though the time in range is well within the 72%, her HbA1c also looks good. But then we can see here that she has time below range of 8%, which is much more than the goal of 4% that we intend to have. So even though it all looks rosy on the surface, it really isn't. Now, why blood sugar handling changes as we age? As we age, we have decreased insulin sensitivity, the pancreatic function declines, there is loss of muscle mass and simultaneously increased visceral fat. Also, the body undergoes various hormonal changes wherein the estrogen and the testosterone decline and there is increase in cortisol. So you can say the glucose homeostasis as we age progresses towards dysglycemia. Due to the various facts that I just mentioned, decreased beta cell function, decreased insulin sensitivity, decreased skeletal mass, increased hepatic glucose output, decreased incretin effect, and glycemic variability. But when we treat these patients, they are also at increased risk of hypoglycemia. What are the causes for hypoglycemia in older adults? They can have poor nutritional intake. They can miss their meals because they keep saying that they're not hungry. There is something called as oral frailty, wherein they will not be able to chew food properly. They will not have that much of a taste capacity. They might have acute illness, vomiting, diarrhea, wherein the food intake significantly comes down. There are significant drug interactions which can happen with the glucose-lowering medications in terms of trimethoprim, sulfamethoxazole, quinolones, salicylates, there is high-dose aspirin, alcohol, ACE inhibitors, and beta blockers. We also see that there is reduced renal function as they age. There are recent medication changes that happen which usually we do not take into account. There are high-risk anti-hyperglycemic drugs the patient will be on like insulin, sulfonylureas. So if we see, they are also at a risk of hyperglycemia because of the age-related changes, but equally at risk for hypoglycemia. Now, we have seen certain landmark trials which have advised us against intensive glycemic control, which we saw in the ACCORD trial. There was 22% increased all-cause mortality and 3-fold increased risk of severe hypoglycemia, and the trial was stopped early. Then we had the advanced trial where there was reduced risk of nephropathy but no reduction in CV or all-cause mortality. The veterans trial, there was no significant reduction in major cardiovascular events when the glycemic targets was set very strictly. Now, recently, there is University of British Columbia that did a therapeutics letter wherein it insisted that HbA1c less than 7% is associated with more harm than benefit. Now, these are certain de-prescribing algorithms that I have picked from the brewery's guidelines or the Canadian de-prescribing network, wherein they ask us to identify the candidates who are supposed to undergo a de-prescribing rhythm, which is high risk of hypoglycemia, frailty or limited life expectancy, having dementia or functional decline, significant adverse drug effects, and multiple comorbidities. In these patients, we have to set individualized glycemic targets. That is, if they have few comorbidities and intact function, we can still stick on to the HbA1c of around 7 to 7.5%. But if they are having multiple comorbidities and are having frailty or functional limitations, the HbA1c can be limited to 8 to 8.5. And end of life care, we have to focus on the function rather than the sugar control. Now, what is frailty? Very briefly, if I have to tell, it is a syndrome characterized by decreased strength, endurance, and physiological function. It means the person has a decreased physiological reserve and anything can push him over the edge, right? So they do not have the tendency to bounce back from an illness quickly. So in these patients especially, we have to think about deprescribing. Now, coming to the next cause, that is the correcting the reversible causes which is making this person prone to hypoglycemia, which I have already discussed in the previous slide. And then the fourth very important step is to deprescribe. We can use one of these three strategies wherein we reduce or stop the inciting agents, especially insulin or sulfonylureas, switch to a lower risk of medication like DPP-4 inhibitor, SGLT2 inhibitor or metformin, and adjust the dose. Adjust the dose of renally eliminated medications like metformin, sitagliptin according to the kidney function. Now, we monitor it over a period of 1 to 2 weeks, check for signs of hyperglycemia when we are deprescribing, check for hypoglycemia or any other adverse effects, and if the blood glucose is stable, we then individualize the target and ensure that there are no adverse effects. So, this is again from the deprescribing network. These are certain medications which we routinely use as antihyperglycemics, which are causing hypoglycemia risk as well, which is insulin, sulfonylureas, and meglitinides to an extent. Now, insulin deprescribing regimens, we have to ensure that most of them are on a basal insulin only, reduce the basal dose by 10 to 20% every 1 to 2 weeks, and monitor for fasting glucose. If they are on a basal bolus regimen, then we stop their bolus, that is the prandial insulin, and continue on the basal insulin and reduce it by 10 to 20% as needed. Then if they are on pre-mixed insulin, it is also recommended that we convert it into basal slowly and maintain 70 to 80% of the dose and discontinue sliding scale if they are on this. Now, what are the outcomes that matter? We do not have to insist on a stricter HbA1c, but what we have to focus on is to ensure that they do not have any falls or fractures, preserve their cognition as much as possible, maintain function and mobility, preserve independence, improve their quality of life, and reduce their treatment burden, and hence reduce hospital visits and costs because of all of this. Now, there are various recommendations by esteemed institutions. We have one by American Diabetes Association, International Diabetes Federation, Journal of American Geriatric Society, then Diabetes Care, Age and Aging, which is a journal of British Geriatric Society, European Association for the Study of Diabetes. All of these recommend the intensification of insulin and oral hypoglycemic therapy in elderly individuals. And these recommendations ensure that our elderly not just have a good quality of life, but also prevent any adverse effects that can happen because of overtreatment. Thank you for this opportunity. I would like to thank Disha, the organizing members, Dr. Manohar sir, for this opportunity to come and speak before you all. Thank you, sir.